Greetings, everyone, and thank you for joining us. This webinar is organized by the Organ Procurement and Transplantation Network, or OPTN. The OPTN brings together medical professionals, transplant recipients, and donor families to develop organ transplantation policy. Our goal with today's presentation is to inform kidney and pancreas transplant candidates and caregivers about upcoming changes to allocation that will create more consistent access to kidney and pancreas transplants. Our panelists include Belinda Jones, MSN, RN Patient and Donor Affairs Representative, OPTN Board of Directors, Vincent Cassingal, MD Chair, OPTN Kidney Transplantation Committee, Silky Niederhaus, MD Chair, OPTN Pancreas Transplantation Committee, and Rachel Forbes, MD, Vice Chair on the OPTN Pancreas Transplantation Committee. If you have a question you'd like to ask our guest panelists, please enter it into the chat box. I will grab your question and present it to the team. We will answer as many questions as time permits. There's a brief survey at the end of this webinar. You are encouraged to provide your earnest feedback. Let's begin. Panelists, I'll turn it over to you.
Thank you, Bernadette. My name is Belinda Jones, and I am a living donor kidney transplant recipient of 11 years. I currently serve on the OPTN Board of Directors, as well as the Executive Committee, the Nominating Committee. I am formerly a member of the Kidney Transplant Committee that during the time that they developed the policies we'll be talking about today. I serve as the liaison from the board to the Transplant Administrators Committee, and I also participate in the Patient Affairs Committee. I was asked to speak today about the patient's role in policy development. So from my perspective, members of the general public represent those that are most directly impacted by the policies that the OPTN Board of Directors ultimately approve. Excuse me. Members of the general public, such as transplant candidates, transplant recipients, living donors, and deceased and living donor families, roles are designed to, one, ask questions that healthcare provider members may not consider from a general public perspective, provide insight into how a policy proposal may or may not be perceived by the general public, such as is it fair, is it equitable, and is it transparent. Submit concerns such as questions, concerns, and recommendations relative to proposed policies during the public comment periods, and encourage other general public individuals to submit their own public comments. Third, these members also make policy recommendations that advocate on behalf of the general public, particularly with regard to equitability in national allocation processes, regardless of where a candidate is listed or lives, organ acceptance practices that minimize the number of unused donated organs, such as organ discards, so that more candidates receive much needed transplants, and priority allocation needs for vulnerable transplant candidate populations, such as children, those who are highly sensitized with CPRAs of 98 to 100%, prior living donors who have previously provided a much needed gift of life to a transplant candidate and are now in need of a transplant themselves, and candidates with hard to match blood types such as blood type B. When I was on dialysis and listed for a kidney transplant, I don't recall being told much about the OPTN or UNIS in general, public comment, and or the opportunities available for people like me to be involved in policy making, providing public comment, and serving on committees or the board in searching my patient education archives. The only things that I found were my listing letter and some UNOS publications, such as Partnering with Your Transplant Team, the Patient's Guide to Transplantation, Living Donation Information You Need to Know, and Kidney Pair Donation. It is through forums such as this one that I pray that more people from the general public will become engaged in policy development and OPTN board and committee service on behalf of transplant candidates, recipients, and living donors and donor families. In closing, I personally fully support the following policies that are pending implementation in December: pancreas removal of DSA, kidney removal of DSA, addressing medically urgent candidates in new kidney allocation policy, distribution of kidneys and pancreata from Alaska, and modifications to released kidney and pancreas allocation. Sorry for my phone in the background. At this point, I will turn it over to either Vince or Silky. I'm not sure who's going to be speaking next. Thank you.
Thanks, Belinda. If you want to advance the slide. Silky, you there? Or am I going?
I'm here.
Got it. All right. I'm going to mute.
I'm muted. I'm smart like that. I have to change my slide size so I can see what I'm talking about. So this is Silky Niederhaus. I'm one of the transplant surgeons. And so the background for this transplant policy development was that the OPTN is the Organ Procurement and Transplantation Network, and United Network for Organ Sharing serves as the OPTN under a federal contract. So policies developed by committees representing donation and transplantation professionals, transplant patients, donor family members, and other views. And these policies are published for public comment from any interested person or group. So anyone can really comment on policies that are proposed. Ultimately, OPTN board votes on these final policies, and then they become active. And after policies are activated, policy impact is studied, and then policies in response to that are updated or improved again as needed. So this is really a cyclical process. Next slide, please. So key factors in kidney and pancreas matching at the moment include how well organs are matched biologically, either by blood type and or tissue type, geographic location of the donor relative to the candidate. So that basically means it's much easier to do a transplant logistically if the organ and the recipient are relatively close. Waiting time makes a difference. How long people have been waiting for an organ should be considered so that there's some amount of fairness in the system. Special consideration is given for our pediatric candidates as opposed to our adult candidates. And some other circumstances for special considerations are people like prior living donors who have donated a kidney to help someone else and ultimately end up needing a transplant themselves. Next slide. So key factors in kidney matching at the moment that are included are the estimated length of a candidate's need for a transplant, which is represented by the estimated post-transplant survival, or EPTS score. The estimated length of a kidney function from a deceased donor, which is represented as the Kidney Donor Profile Index, or KDPI. Priority is given for kidney offers likely to function the longest, so low KDPI kidneys for candidates who may need them for the longest. So those are generally the low EPTS recipients. So, and that's done in order to minimize how many transplants a person needs in their lifetime. There is increasing priority for highly immune sensitized candidates, so that's measured by this thing called a calculated panel reactive antibody, or CPRA. And there is medical urgency priority for a small subset of candidates who lose dialysis access, so they can jump near the front of the list. Next slide, please. Key factors in pancreas matching include medical criteria that qualify the patient to be listed. So examples like that include insulin dependence with additional complications or severe exocrine insufficiency. And then the other thing is a need for a pancreas alone versus combined kidney and pancreas, or multiple other organs, including a pancreas. Next slide. So what role does geography play now? Our current system is based on what we call a local donation service area, or DSA. Second, the region that's like the size above it is the region. And lastly, there is our nation, resulting in a national allocation system. Next. Why are we looking at changing the system? Because there are local and regional boundaries that are inconsistent and not designed to optimize organ allocation. There are differences, these differences, they contribute to inconsistent waiting time or access to transplant in different parts of the country. So if you live near a coast, often your waiting time is longer than if you live in the center of the country. And the OPTN has already eliminated DSA from region, from other organ systems to reduce disparity in access. Next slide. Sorry. Oh yeah, there we are. Key goals of the new system would be to reduce geographic effects on transplant access, and to create more consistent geographic areas for distribution. Some DSAs are very differently sized and shaped than others at the moment, so we're trying to make this more consistent for everyone. Next. So what things are not changing? For the moment, we're not planning to change how waiting time is assigned or how much priority is given based on waiting time. We're not planning to change how pancreas candidates qualify for listing. We are not planning to change the priority that kidney candidates get based on their EPTS and KDPI matching, and we're not planning to change any priority based on immune sensitivity. What things are changing, so there will be new and consistent local boundaries that will not be called DSA anymore, and we're going to eliminate the idea of a region for organ allocation. There are going to be additional allocation points inside the new local boundary and beyond the local boundary based on how close the transplant hospital is to the donor hospital. And we're going to have adjusted priority for pediatric candidates and prior living donors. Because when these priority points were created, the waiting times were very different from how they are now. So we want to give these special populations their appropriate priority. Next slide. What things are changing? We're continuing here. One thing that is changing is the updated definition of medical urgency for kidney candidates, and that's something our kidney committee under Vince's leadership has worked hard on. We're changing into updated procedures for reallocating organs that were initially accepted for one candidate but ultimately weren't able to be used for transplantation. So we want those organs to be most likely transplanted rather than discarded. And we're planning to change specific adjustments to matching of donor organs from Alaska because there's no transplant center in Alaska, so it would be tough to fly these organs for large distances. Next slide. In the new distribution sequence, the first level of organ offers will go to candidates who are located at hospitals or registered at hospitals within a 250 nautical mile circle around the donor hospital. So if you imagine, donors can be at any hospital in the country, so these circles are centered around any hospital in the country. If no recipient can be located who's willing to accept that organ on that list, then the organs will be offered secondarily to candidates at hospitals that are beyond 250 nautical miles away from the donor hospital. The way this is going to be done, we're going to add some proximity points to the candidate's allocation score. So within the 250 nautical mile circle, the closest patient, so if the organ recovery is in the same hospital as the transplant center would be located, you would get 2 points added for proximity, as opposed to if you're registered in a different hospital that's 249 miles away, you would get close to 0 points, and anything in between will be linearly allocated. And outside the circle, similarly, you get 4 points for being 250 nautical miles away exactly, and then this tapers down to 0. The further you get away. Furthermore, for our Alaska donors, Seattle-Tacoma International Airport will substitute for all the Alaska donor hospitals as the center of the 250 nautical mile circle to allow for Alaska to have a relatively sensical 250 nautical mile circle, since no transplant center would be otherwise included in that, and since most organs fly through SeaTac anyway. Next slide. So current distribution, our local example is this right here. You see the University of Kansas Hospital. right here, you have each color-coded area that is a different local donation service area. So you have Kansas, you have Nebraska, Iowa, Illinois, Missouri is part of Kansas, but the other half is part of MoMA. And so local donors would be considered in the MWOB service area, which is here. It's the purple color, right? And so in MWOB, this is where these organs would first go. If nobody within this local area would be interested in that organ, then it would be offered out to the region, which probably includes some neighboring OPOs. Next slide. And you can see in this, actually, if you go back for just 1 second, you can see, I'm making it complicated today, sorry. But I think here you can see that even within this purple local area, there are some candidates that are really rather far away, and some candidates in neighboring OPO areas or donor service areas ultimately that are actually much closer than the furthest in the purple area would be. Now we'll go to the next slide. In the new local distribution example, instead of having different OPOs, then we would have a circle instead around the Kansas hospital right here. And all transplant hospitals or centers within this 250 nautical mile circle would be considered equal in terms of the recipients that are located there, with the exception of this 2-point distribution inside the circle, where people closer would get 2 points and people more distant in the circle would get closer to 0 points for proximity. Next slide. So proximity points are additional allocation points that will be added to a candidate's score based on their distance between the transplant hospital and the donor hospital. This obviously will change for every single individual organ offer. A shorter distance will equal the highest number of points. One proximity point is about the number of points a candidate receives for 1 year of waiting time. Candidates may get a decimal value score, for example, 1.7, not just whole numbers. And within the 250 nautical mile circle, you can get up to 2 points for being at the exact same location as the donor. Outside the circle, up to 4 points would be the maximum. And then 0 points will be added for distance over 2,500 nautical miles. Next slide. So here's our proximity points example, and I think this is a lot easier to understand than these graphics we had earlier. If you look at the donor hospital, let's pretend again this could be Kansas Hospital. We've drawn a 250 nautical mile circle around it. If you now compare 3 different candidates, candidate A near the edge of that circle, but inside it, would get 0 allocation points. Candidate B, located exactly between the center of the circle and the outside of the circle, would receive 1 point. And candidate C is outside the circle, they would get 4 points. However, only if candidates A and B said no to this organ, and all other candidates within the circle. Next slide. So the expectations and statistical predictions of the new system, we were really hoping to reduce variation in wait times across different areas of the country to offer more equity in transplant access. We were hoping to increase pancreas utilization, and we have found based on our modeling that this may actually happen, and we may actually also increase our pediatric transplants. Obviously, once the system goes into effect, all these effects that may change will be monitored and addressed as needed. Modeling is only modeling. It doesn't actually reflect human behavior. So surgeons and physicians who make these organ acceptance decisions may make decisions that the modeling system did not expect. And so we want to make sure after this is implemented that everything is monitored, and if there are discrepancies that we address them in a timely fashion. Next slide. So what do I need to do? At the moment, as a listed patient, you have nothing to do. You don't need to provide any new data or medical follow-up to your transplant center or to UNOS. There are no changes to your individual status. Now, you should stay in touch with your team anyway to make sure all your information stays up to date at all times. You should be aware of changes. You should ask your transplant team any questions that you may have of how, you know, distributing organs differently may affect you, and this may quite vary depending on which parts of the country you live in. So that's, I think, an important thing to know. The next slide. How can you find out more? One, you can ask your transplant team. Two, you can go to the OPTN website that you see listed here. It's optn.transplant.hrsa.gov. You can email UNOS at patientservices@unos.org, or you can call UNOS Patient Services at 888-894-6361. Next slide. We are here to take any of your questions. I think I can speak for all of us, myself, Dr. Cassingnal, and Belinda, that we've all thought hard about this, and we hope that these changes will be beneficial to our transplant community as a whole. So thank you for listening in today.
Thank you to our panelists, and thank you to everyone who has joined. We'll now take some questions. As a reminder, you can submit your question into the chat box. And we do have a question here that is inquiring if this presentation will be available on the website. And I know we will be posting that onto the OPTN website, and our unos.org website will point to the OPTN as well. We have a question here that says, would someone please be able to give just a brief breakdown on how this will impact rural transplant centers? Is this being viewed as a positive, being able to provide more offers to patients in these areas? It sounds as if they will be given more points if they are outside of the circle.
Yeah, so as far as rural transplant centers versus urban transplant centers, we really didn't see any great changes in organ distribution. You will get more points outside the circle, but you have to remember that the organs will not go outside the circle ideally, right? Ideally, we want to use the organs within their circle, but you also have to remember that for every single donor, the circle changes. And so because, you know, some hospitals have more frequent organ donors than others, those circles will more likely end up around those hospitals. But overall, the circles are big enough to have quite a number of donor hospitals within them each time. And because they're designed to vary and overlap in different areas, there's going to be no real change to how likely you are to get an organ offer in a rural setting versus an urban setting.
Another question here. You mentioned a variation for Alaska. Is there a similar procedure for Hawaii? We have one transplant hospital, but many patients travel to the West Coast for transplant.
So for Hawaii and even Puerto Rico, oh, Vince, you want to talk about it? Go ahead.
I'll take that question, and I think they nailed it with the question. Is there are transplant centers, kidney transplant centers, both in Hawaii and Puerto Rico, and those kidneys, we would like for them to be able to stay as close to home as possible, because we do recognize that moving kidneys back and forth is very costly and can affect the outcomes. The difference with Alaska is that there's not a kidney transplant program there. And so our intention was, where is the most efficient place and what is the most efficient way to get those kidneys into the transplant community? And we felt like getting those to Seattle-Tacoma Airport and distributing them as close to possible as there was probably the best for those 40 kidneys or so, 40 donors a year or so that we see out of Alaska. The comment was made that a lot of people go from Hawaii to the West Coast, or people from Alaska do tend to go to the Seattle-Tacoma area. And we think that the remainder of the allocation system will allow for sharing pretty broadly on the mainland, and that the geographically removed areas, Alaska, Hawaii, and Puerto Rico, don't make that huge of a difference to wait times.
Another question here. How is this going to impact patients who are listed at different transplant centers in different regions?
Yeah, I mean, our hope is that the wait times will be closer amongst the different regions. If people remember, one of the reasons why we wanted to change this is because where you lived made a difference for how long you waited. And that's probably one of the biggest things that affected how long you wait. And so our hope is that as this system gets up and running, those wait times become more similar.
Yeah. Vince, can I add on to that?
Please.
I think the other implication of that is that if you're currently listed in a center that has high wait times because of how organs have been allocated up until now, then your waiting time may decrease slightly. I think the other thing is if you're currently listed at a center that has below average wait times, your wait time may increase slightly. The most key thing to remember about all of that is that waiting times in general are going up throughout the country, so that a lot of patients, are operating under the waiting time that they were told when they were seen for their initial evaluation. But now that they've waited for 5-6 years, the waiting time is a year or two longer than what was originally anticipated. That's because transplants have been so successful and there's still a great donor organ shortage. And the other thing is that wait time can be dramatically affected by whether or not you're able to find a living donor for yourself. So I think to any patient listening, if you're waiting for a kidney transplant, the waiting times are not in your favor. And you should definitely tell your family that the doctor said you should always be on the lookout for a living kidney donor.
We have another question here. Hello, when do these changes become effective?
Yeah, I think they're planning to be effective come December. UNO's implementation date is...
Is it 14th or 15th? Somebody from UNOS on there?
Vince, this is Belinda. I believe it's the 15th.
15th, December 15th.
There are many questions about will the recording be available later, and the answer to that is yes. We will post it onto the OPTN website, and the link on unos.org will also have a link to the OPTN website as well. We have another question here. So what does that mean for those who are way outside of the circle, less likely to have a chance to get a donor, period?
So as Silke mentioned, the circles are moving based on where the donors are located. And so a donor located, let's say I'm in North Carolina, located in North Carolina, that kidney will most likely stay inside that circle. And that's on purpose because there's a lot of reasons to keep kidneys locally. But remember, if you're outside the circle, and so you are in, let's say, Texas, for those donors in Texas, you are inside that circle, and that's most likely 90% of the time that's where you'll be getting your kidney from, are from donors that are inside your circle, or you are inside their circle. And so this is an efficient way to run things. This is basically how we do it now. Is kidneys tend to stay local. There's a lot of reasons we share kidneys nationally. We're still going to be sharing those kidneys nationally, but most likely you will be getting a kidney that's within 250 miles of you for the most part. And that's this is a good way to share those kidneys so that you don't just get them from inside what used to be your donor service area. I use the example as we were talking about this. I'm in Charlotte, North Carolina. I'm 9 miles from the South Carolina border. There's a hospital about 15 miles from here that I do not get any kidneys from up until this point. 15-mile away hospital, no kidneys come to Charlotte, North Carolina. In the new system, they will be considered within that circle and will be able to share kidneys. In the same fashion, we don't share kidneys with Georgia, which is not very far. In the new system, we will be able to share kidneys with Georgia.
There are many questions asking about listings at multiple hospitals. Is there still a benefit to be on more than one hospital list?
This is Silky. I can answer that question. I'm a transplant recipient too. So part of the reason we're trying to change this to this newer system is that multiple listing is something that at the moment not every single candidate can afford. And so it's not fair that people who live in a region like New York City or San Francisco, where waiting times are 10 years or higher, would have to wait that long when they really have no other choice, right? That's sort of what motivated this to some extent. But that said, I think multi-listing at different hospitals still makes a lot of sense, right? Because if you're listed, say, currently I'm in Maryland, so this is what I did when I was looking for my second kidney transplant recently. As I listed in Maryland, and my Maryland donor hospitals or the hospitals nearby that are within a 250 nautical mile radius of here is a certain number of hospitals. And there could be a better match at a hospital in Wisconsin, but I would be near the bottom of that list, being outside of that 250 nautical mile circle. So I could double list in Wisconsin. I could still double list in California or Texas or really, Alabama, any place I would choose to go. And I may draw some advantage from that still, just because a different donor has different tissue typing, different age profile, different all sorts of things. And based on that, I may come up higher or lower on any given list at any time. So I think there will still be an advantage. It may not be as dramatic as it is now. But I think, with multiple listing, I don't think you can really ever go wrong. The biggest advantage is still the living donor, and that's ultimately what I ended up going with. I was lucky enough to run a campaign and find one. So those kidneys are healthier, they last longer, the recovery is very standard, very easy. The deceased donors all go through death before they're able to donate. And so those organs they're still good. They still help us transplant candidates a lot, but they've still been through a little more.
We have a question here. In your modeling, did you see wait time drop significantly? In California, we have 10-year wait times.
Vince, do you remember the data from that?
Yeah, there are certain areas where the transplant rates go up, and some it's more significant. The reason I can't say that wait times go down significantly is because you remember this is a model that that shows how things look as the list is today. It doesn't necessarily show where things are in a year, 2 years, 3 years. And so it seems like the transplant rate will go up in certain areas and it'll tend to be more even. California is still a difficult area because as you get towards the middle of the country, you're not really 250 miles from the Midwest by any means. And so there are areas in California that do get better, their transplant rates get better. There are some areas where it's much more significant, and I guess the answer to the question is that is something we will be tracking every 6 months. We think it's getting better in most areas of the country that have the long wait times. And as Silky mentioned, there are some areas where you may wait longer now. And so that is one thing that we're tracking. What we do see is that more places seem to be waiting a similar amount of time. So we're moving more towards the same length of time.
Vince, this is Belinda. I'd just like to add that I was listed in California, and when I was first listed, the wait time was 5 years. Then it went to 7 years, then up to 10 years. So I was fortunate enough, like Silky, to end up with a living donor. But from my perspective, this will at least kind of help level the playing field, that just because I physically lived in California, I had to wait longer than if I had gone back to my home state of Indiana. I could have probably been transplanted in 2 years. So hopefully with these changes, we will see patients waiting a more equitable amount of time across the country as opposed to huge disparities.
Thanks for that, Belinda. And as you know, I mean, Belinda was on these work groups, and her input very valuable, and that was our intention and hopes as well. And we're looking forward to following to make sure that we see that come to fruition.
Yeah, and I think, Belinda, you totally nailed it, really, because you say it levels the playing field, which I totally agree with, but will waiting times really decrease dramatically? And unless we figure out a different way to recover organs that we cannot currently use for transplantation, I think waiting times will continue to increase because kidney disease is increasing in our country. And our organ donor pool is not really getting healthier. And, we're always working in medicine on ways to keep people from dying. So I think, if anything, the waiting times will probably continue to increase for some time overall, unfortunately.
Does the point system only go into play if all candidates within the 250-mile radius from the transplant hospital decline?
No, the point system is in play already, right? At the moment, organs are allocated by points. Just the point system for kidney allocation is extremely complicated. So for every day that you've been listed since you've either started dialysis or your glomerular filtration rate has been less than 20, for every day that you've spent on the list, you get assigned one 365th point. And then you get points added to your waiting time based on certain other factors. So I think if you're a child of a certain age, you get either 2 or 4 additional points. If you have a certain HLA match to the donor that's an outstanding match, you get an additional 4 points. So the point system is already in place. The trouble is that the points that you have for every donor on the list are different. So every day a new donor comes up or 2 new donors come up, and your points number goes up and down depending on certain factors of how you and that donor would do, if we combined the two. And so it's a very difficult to understand system. And even when I've tried to explain it to other physician colleagues, I get nothing but big eyes and many questions. So these points will just be basically replacing points that we previously gave for, being close. We'll now have points instead of being close is limited to an ugly shaped area. Being close will be based on a circle. So I don't know if that clarifies. It's organ allocation is complicated.
How does this new system impact the organ procurement organizations?
So the OPOs should not have to change how they run the list. That will stay the same. It will change where some of these organs are going. And so they have put things in place that I use the example of an organ in South Carolina now coming here. They'll have to change their workflow and develop those processes to get an organ to North Carolina instead of keeping it in South Carolina. And so it's something that the OPOs are very good at doing. This matches how they do things for liver transplant, lung transplant, and so it really is just what I would consider a little bit of a different change, but not something that they haven't done already. A lot of work went into not making this cost prohibitive and not giving up efficiencies. One of the issues we see in the modeling is we didn't want kidneys to be lost in transit. We didn't want them to be lost on planes. And the modeling shows that kidneys should fly less, so we'll be relying upon commercial airlines less if things come to fruition, and that the travel times should stay within an acceptable range.
I'll take this time now to remind all of our attendees, if you have a question, you can submit your question into the chat box. We have one here, panelist. What if the circle encompasses several close-by states? Is the preference given to the recipients in that state of the donor within the circle first?
So it won't be based on states. All the recipients inside that circle, and when we say recipients inside that circle, the recipient transplant centers in that circle. So if you are registered at a transplant center in that circle, everybody is on that inside the circle list, and that's where the points come in. And so there will be some extra points given to keep things closer to the donor hospital. Those are those proximity points. But if you've been waiting longer than a hospital, if you've been waiting longer, you'll have points in that way. And as Silky said, it's very a complicated matter. There's a lot of ways to get points. The reason we do that is to try to get the kidney to the patient who's been waiting the longest, has the best match, etc. And if all things are equal, if all patients are equal, whether they're 100 miles away or 250 miles away or 1 mile away, if all things are equal, we tend to give it to the closest recipient. But there are a lot of good reasons why a recipient 250 miles away should be first on that list. So the answer is it's not based on the state, it's based on all the points put together that make up an organ allocation score.
Yeah, and Vince, I think it's important to note that even before in our current system, for some areas currently, the donor service area or the DSA would have been a state, but for many others, it would have been a certain number of counties, or some counties here and some counties there. And it was a very irregular distribution, and so that was some of the original thought that, you know, sometimes crossing a state line means recipients are closer than if you go to the complete opposite end of the state. So if you imagine being in very far southeast Texas, you're probably closer to some of the Louisiana transplant centers than you might be to centers in Dallas, just from a physical distance. And so why ship organs over a longer distance just to keep them in the state when patients are waiting in both areas, and we can keep, you know, kidneys that are closer to Dallas, or kidneys from maybe Northwest Louisiana would go, you know, to Northeast Texas. So I think that's, even in today's day, not all donor service areas were exactly represented by state lines.
We have another question here. Is priority given to those who need double transplant versus single organ transplant?
That is a complicated question that UNOS is working on. And so if you mean that double organ transplant, meaning let's say a heart kidney or a liver kidney or lung kidney? The answer is it depends on the donor. So if it's a good heart donor, then a heart kidney may be allocated. And when I say good heart donor, a good match, et cetera, et cetera. If it is an eligible lung donor, but not a kidney donor, then obviously the organ procurement organizations don't go in that direction. And so the OPOs have flexibility making those decisions based on the state of the heart, the state of the lung, the state of the kidneys, et cetera. If the question is dual organ being dual kidney transplant, that was a policy that went into effect a few years ago using 2 kidneys for 1 recipient. And the reason we use 2 kidneys is for some donors that have some underlying kidney disease, using 2 kidneys works and using 1 kidney doesn't work. And so in those situations, there is some matching that goes on with certain recipients. There is a lot of work going on with UNOS trying to weigh when to use a multi-organ, heart kidney versus kidney alone versus lung kidney versus kidney alone. And it's just different with every donor because of donor issues and recipient issues.
What occurs when your transplant area includes the ocean?
Yeah, so good question. What we found with those centers is if your donor hospital is around the ocean, obviously those organs don't go out 250 miles, let's say east, on the East Coast. But it seems that the most highly dense populations in this country tend to be on the coast. And so we found that those organs are still utilized in a very efficient fashion because there are many transplant centers within 250 miles of the coast. And so we did not find that those organs were not going to be placed in an efficient fashion.
We have another question about the nautical mile decision. I'm curious about the nautical miles. It intuitively makes sense, but implies equal time transportation of a donated organ despite geographical features. A mountain range takes longer than a flat plain of a farther distance. So is air flight, helicopter plane the default in this calculation? It is probably too complicated to figure out average time distance from each transplant center rather than a nautical circle, but is it something to note in seeing the data from implementation?
I think you nailed it. That's a fantastic question. And to be honest, we used nautical miles for the sole reason that we needed to look for a surrogate. And we didn't want irregular state borders to prevent closer patients from getting access to organs. Ideally, and we're not quite technologically savvy yet, right? Ideally, you would want to know exactly how long the transport from a donor hospital to any given center would take. And you would adjust that by time of day of the organ recovery because certain airplanes and airlines fly at certain times, not other times, and traffic makes a difference, and city makes a difference, and all those sorts of things. And the logistics of calculating that was just going to be just about impossible. And so we decided instead to just go with the simple idea of circles for now. Interestingly, this is not hopefully the final plan for organ allocation. We're working even already as we speak to move to the next stage, which we will call continuous distribution. So be on the lookout for updates yet to come. But yeah, if we were as fancy as, you know, Amazon perhaps or some other companies, then we might be able to figure out precise locations of airports in relation to donor hospital where you could fly it, and in some cases flying it a longer distance may be faster than driving it a shorter distance, relatively speaking, right? So these are all very complicated questions, and so we used a very rough surrogate of the nautical mile.
Could this create unforeseen adverse effects for the OPOs in hospitals, changing OPO practices?
Yes, of course, any unforeseen effects could happen, right? That's part of the reason we always, when we make changes like this, we insist on monitoring afterwards, so that if the unforeseen changes are major and have a negative effect, that we can then immediately intervene on them and address them. But we don't really suspect that anything will be, you know, terribly different for OPOs. For some transplant centers, there may be, you know, acute changes that they may notice, but we've just been through a bunch of acute changes this year with everything that's been going on with our pandemic. So I think we've never been better equipped to deal with unforeseen changes compared to where we are now.
How might any of this affect someone who's waiting for a kidney and a liver?
Yeah, so hopefully not at all is our thoughts. The way somebody who is allocated a kidney and a liver is that the liver is allocated, and when there's a kidney available, then that kidney is offered, and there are some rules behind that. And so that should not affect how those patients get offers, because the liver allocation is not changing at all. So the liver allocation isn't changing. So we don't foresee a big difference in simultaneous liver kidney allocation.
Yeah, I don't think it'll change. I agree with Vince. I think the kidney will follow the liver if there's a suitable kidney to be found in that liver donor. And that's unlikely to change with this.
We have a question here. What about those in Guam? Do they go to Hawaii?
That is a great question. I have never heard that question. Silky, do you happen to know it? Or maybe somebody from UNOS?
Yeah, that's a really great question. I think it probably depends on the Hawaii OPO, if they'd be willing to travel that far to get the organ shipped over, or how the systems there work currently. But if there's no transplant center in Guam, I'm pretty sure that, you know, if the organ's quite suitable, people might go and pick that up. But I don't know how they're currently allocated.
We have just a few more minutes here. I will remind all of our attendees that if you have questions for our panelists, please submit it into the chat box. I will grab your question and present it. And for those inquiring, yes, this presentation will be available on the OPTN website. We will also post it onto unos.org and link to the OPTN website as well. Just waiting for additional questions to come in here. Sorry, my computer, my two screens went haywires on me.
So I think Silky mentioned this, and we might have mentioned this for everyone. We have a plan to track how this is going, and so we will be following this data over the next number of months to years, with our commitment that if things don't look right, that that UNOS has a commitment to make sure that organs are used safely, make sure that organs are not wasted, to make sure that we're doing the right thing. And so the kidney committee, the pancreas committee, where Silky and I volunteer, is committed to making sure that we are not making things worse.
We have a question here. What happens when your transplant center will now include 3 major metropolitan areas, New York City, Philly, and Boston?
So take, for instance, if you were a New York City transplant program, the majority of your organs would come from New York. And now what we expect is that your organs will come from a mix of places, Boston, Philadelphia, New York, but that some of those can be shared. The organs in New York will be shared with Boston, Philadelphia, and then some of those in Philadelphia may be shared with Maryland and Baltimore and DC, and that there's a fluid sharing of organs around the country versus organs not being shared, let's say, across the Hudson River, so that people on each side of the Hudson wait around the same amount of time.
We have just a few more questions here and a few more minutes as well. Someone says, how does this impact the kidney exchange program?
This should not affect the kidney exchange programs. The UNOS KPD is still a national program. The majority of KPDs are either regional or national, and we don't intend for those to go away by any means.
Do you foresee decrease in high-performing transplant centers' deceased donor rates since organs might not stay in their immediate area?
We hope not. We are hoping and expecting programs to perform at the highest level, accept organs at the highest level, just as they normally do. And so we are not predicting that changing where the organs come from will change how people perform. We are hoping that this distribution, this more even distribution, will only do that, which is make it a little bit more equitable from a geography standpoint.
Is any priority given to the primary center?
So when you say primary center, if that is a center at a donor hospital, then the priority is given via the points, but it's not an absolute priority. So if there's an organ at a hospital that has a transplant center in New York, they will get 2 points for being 0 miles from that center. If there's a hospital transplant center 5 miles down the road, they will be getting 1.9 something points. And so it will be a mild benefit to the transplant center located at the donor hospital, but it's not absolute.
How does this affect smaller transplant centers who see a sharp decline in available organs?
So there are some smaller programs that will see a decline in organ offers, and there'll be potentially some that will see an increase in organ offers. It really isn't based on how big your transplant center size is. The offers go to patients. They don't go to transplant centers. And so it's those patients that have the most points, which is mainly wait time. So those patients who've waited the longest will be getting those offers. So it's not a transplant center that gets the offer, it's the patient does. So those patients that have been waiting the longest will be getting those offers more evenly with this new system. The real question is will this hurt certain centers? And I suspect some centers will do fewer transplants next year, and some centers will be doing more. And we will have to track how that looks for all those reasons. But our intention is that from a patient standpoint, from a recipient standpoint, this is only more fair to those patients through the country.
Thank you. And that will be our last question for today. That concludes today's webinar. Special thanks to our panelists. Please remember there will be a short survey at the end of the webinar. Please provide any feedback you deem appropriate. Thanks again. Stay safe and stay well.